Thank you very much. First of all, I would like to begin by thanking the Great Wall International Congress of Cardiology for inviting me and having me in this wonderful meeting. It's truly an honor. I will talk about cardiac resynchronization therapy, how to improve responder rate. Now, despite 2.5 decades of CRT, we find that the response to CRT is somehow quite variable. There is a group of patients who have a very good trajectory where we find that there is a very rapid remodeling of the ventricle, and there is a very good improvement in ejection fraction. We call them super responders. Another 35-40% patients also show good amount of response, but about 1/3 of patients can be considered non-responders, which may again belong to three categories. Some of them have a flat outcome. We can call them non-progressors. The patient says, I have not improved. So, and then we have two non-responders, and some patients actually may deteriorate. So we have been facing this challenge with the cardiac resynchronization therapy for a long time. Initially, when the indications were somewhat different, the non-responder rate was high. But now with the improvement in the case selection and also improvement in the leads available, quadripolar leads and multi-point pacing, etc., the responder rate has gone up significantly. And we find that a much larger number of patients are now considered responders, maybe 80 to 90%, if we follow the guidelines clearly. Now, this also depends on what criteria we follow as far as the defining the response is concerned. If we follow echocardiographic criteria, which typically involves improvement of LV ejection fraction of 5% or more, and a reduction in the LV and systolic volume of 10 to 15% or more, about 75% patients can be considered responder. And if we consider only NYHA class, like for example, one functional class improvement, then the responder rate may be as high as 90%. But it is very important to understand that the mortality of patients with non-responders is very high compared to responders. As this slide very powerfully shows, the Kaplan-Meier curves for all-cause mortality are very divergent between the responding patients and non-responding patients. So we must make every effort to make our patients respond to CRT. Now, this slide shows the predictors of non-response to CRT and how we typically measure the response to CRT. On the left side, we have the most common reasons why some of our patients do not respond. It could be various arrhythmias, including atrial arrhythmia, and even PVCs can affect the delivery of resynchronization therapy and affect the overall improvement. Then we now know very well that patients who have a shorter QRS duration, typically less than 150, they would have lesser response compared to those who have very wide QRS, more than 150 milliseconds. And the non-LBBB QRS patients, even if the QRS complex is wide, they do not respond very well. Ischemic etiology patients have a lot of scar in the ventricle. They don't respond so well. And patients who have a very severe heart failure in NYHA class 4, they also don't respond very well. And patients who have significant dysynchrony and echo, but the QRS is narrow, or those who have severe right ventricular dysfunction, they also do not show very good response to CRT. I will not go into the details of how we evaluate, but we can evaluate the response by quality of life, by echocardiographic parameters, which I just described, by ECG narrowing, which is a very easily available surrogate for judging the possible response to CRT. And we, at the time of implantation, that is the most important parameter that we look at, because that is going to decide. We cannot do so many other parameters at the time of implantation, but QRS narrowing is something that's a very important surrogate to measure the likelihood of response to CRT. And then, of course, we have later outcomes like hospitalization and mortality, which can compare the response in larger groups. Now, selecting so pacing site is most important. We must pace the lateral wall of the left ventricle and try to achieve the maximum separation between the LV and the RV lead. So that's of fundamental importance. And of course, stable lead position, acceptable threshold, and absence of cranial stimulation. These are very fundamental points. And also at the time of implantation, we must look at the RV sense and the LV sense electrograms and try to get maximum interval between the two, because physical separation of RV and LV lead is important, and the electrogram separation is also equally important. Another measure to consider is QLV, which is measured from the onset of the QRS complex to the LV sense. So QLV of at least 100 should be achieved. Now, during the LV lead placement, we are typically dependent on the venous anatomy, and many a times we don't have too many veins available for selecting the proper vein. But if we do imaging properly beforehand, so if we look at the venous anatomy beforehand, and also during the implant, there are techniques by which we can find out which are the areas which are contracting or activated in the end by electroanatomical mapping, and also which are at the same time which are healthy also, that is they have a good voltage. And cardiac magnetic imaging or strain rate imaging of the left ventricle can be done beforehand, and we can find the areas which are activated in the end, which don't have much scar, and which are otherwise healthy also. So it is not possible in every case because of cost constraints also, resource constraints also, but in certain situations where we find that patient has ischemic background and a lot of scarring is present, we can try to find out the areas which are going to be good targets for placement of LV lead. Then many speakers are going to talk about the LOT CRT and HOT CRT, that is lap bundle branch area pacing, combining with the traditional epicardial LV lead placement or his bundle lead placement in addition to the conventional lead. And it has been shown in many studies. I will not go into details of data because that will be discussed in other talks. So it has been shown that it can be used either as a de novo implantation or as a primary strategy in some patients, or it can be used as a rescue approach where the initial approach is suboptimal. We don't find good vein, we don't find good parameters, and we know that the likelihood of response may not be very good. We can use it as a additional lead, or we can use it as an upgrade when we have done traditional ICT and we find that the patient is not responding. We can upgrade to a LOT CRT or HOT CRT. And in many studies, which will be discussed in this session, it has been found that we can find much narrower QRS complex with one involving the conduction system pacing along with traditional CRT. And the clinical response is also much, much better. And of course, ECG, as I said earlier, can be used as a surrogate. So what to do after the implantation? After implantation, we must make sure that the patient has good CRT pacing percentage. We must evaluate the device performance. We must optimize the device parameters. And of course, we should not forget that guideline-directed drug therapy and lifestyle and comorbidity management are essential for heart failure management, and they can improve the response also, because some patients become very relaxed while they have CRT. They don't take the drug therapy and the lifestyle modification and comorbidity management very seriously. So we must continue to improve on that. So there is enough data to suggest that we should try to achieve upward of 97 or 98% pacing for CRT to be most effective. So that is the objective. And for that, we can take several measures in the device programming. We should shorten the AV delay to minimize fusion. We can, or optimize fusion. We can use rate adaptive AV delay. We can program upper tracking rate enough to track sinus rate, shorten PVAR to achieve higher upper tracking rate, and also optimize other parameters. There are some specialized algorithms which we can be used in patients with atrial fibrillation, like the conducted AF response or ventricular sense response. There is no time to go in details of them, but these specialized algorithms can be used to maximize the capture in patients with CRT. And if the patient continues to have high ventricular rate and atrial fibrillation episodes, eventually we may have to consider ablation of the AV node, which will make the patient pacemaker dependent. But it has been found to be quite effective in many studies, including the certified study, where they found that the results of AV node ablation in patient with atrial fibrillation were as good as those in the sinus rhythm. Another important thing is to basically make sure that the patient has good sensing and capture. So I will again not go into the details of this, but on every visit, we should make sure that the sensitivity settings are good and the threshold and output programming is appropriate for the patient. The lower and upper rates are carefully programmed. The rate response is carefully programmed because we don't want too high a rate for the heart failure patients. Our best target for these heart failure patients is to keep the heart rate between 60 and 90. If we keep the heart rate very high, the patient may not respond very well because we know that heart failure reduction is an important part of the heart failure management. And of course, we should look at the battery parameters. LV anodal capture is a it used to be, now it is not so common because we have very good device parameters but in earlier times, LV anode capture from the RV ring was a problem, especially in CRT patients. Quadripolar LV read is now standard, which can also be used for multi-point pacing, which has been shown to benefit certain category of patients, especially if non-responders. Initially, we don't put it on in every patient, but patients who are non-responders, we can switch it on. And if the lead is in good position and we can capture from the tip and the most proximal electrode, that will give the widest area of now, the device programming can also be done by AV and VV optimization. The aim is to maximize diastolic filling time and to minimize the aortic pre-ejection period to optimum level. And of course, we should try to minimize the mechanical dysfunction. Now, various studies have shown that atrioventricular timing is a very critical component of device programming. And a lot of patients with non-response, they have suboptimal AV timing. Other parameters, of course, are anemia and arrhythmia and suboptimal lead position, etc. But this is something which we can help with. And there are new algorithms like Sync AVC are available, which is with Abbott, and there are other AV optimization parameters which are available from Medtronic, which can help many patients. So in this particular study, we can see that the Sync AV can really shorten the AV delay by optimizing the various components of myocardial depolarization. And adaptive CRT can also be used to good effect in many patients who have a Medtronic device and who have intrinsic conduction. So the idea is to utilize the intrinsic conduction from the right bundle and the LV-based depolarization wave and try to achieve the best fusion, which will give us a narrowest QRS complex. Now, of late, there are efforts to involve artificial intelligence models in prediction of response to CRT. And this is a very detailed slide. I'm afraid we don't have much time to discuss all of these parameters, but this was a very large systematic review involving 14,000 patients and 29 AI models were tested in 22 studies. And they found that the predictive value of these parameters was very high. So a large number of parameters can be fed in the AI models and which can predict the response to CRT in patients, which can then subsequently be used to improve the clinical decision making. We may want to do more pre-procedure imaging studies in those patients. So let us not forget that in any CRT patients or any heart failure patient, we must make sure that the patient is not neglecting the essential components of the drug therapy. And all the quadruple therapy should be given to our patients. And if patient is not responding, we can add additional medicines like vericiguat or ivabradine, etc., to control the heart rate. In some patients where the sinus rate is very high and we have kept upper tracking rate low, it is very necessary to have some strategy in place to control the heart rate by ivabradine or beta blockers or other drugs to so that effective CRT can be given. And then we must ensure good compliance with other aspects of lifestyle like salt and food management. We must recognize and treat precipitating factors like anemia, azotemia, arrhythmias, etc., and address other underlying cardiac diseases like myocardial ischemia or valvular lesions. And we should always emphasize to the patient about the importance of lifestyle change, optimizing weight and exercise, etc. Now, in a recent review, was a very good suggested protocol for managing patients after device implantation. So we can begin with AV and VV optimization. So we can look at real-time surface ECG and echocardiography parameters and try to achieve upward of 98% CRT delivery and QRS narrowing of more than 20% and a good pulse wave Doppler with distinct D and A waves. And on the first and 6 months follow-up, we should look at the clinical history, physical examination, and other ECG and echo and quality of life assessment. And at this point of time, the electrophysiologist can do the device check, look at the AF or PVC burden, and take action accordingly. QRS duration and mitral inflow can be looked at, and we can do further appropriate programming. And the heart failure specialist can also be involved who can do the NYHA class and the CPAT and the 6-minute walking test, etc. and continue to make sure that the patient is compliant to therapy. And further AV/VV optimization can be achieved and rate control for AF is a very, very important component of CRT management. So I think I will stop here and take if there is any question, I'll be very happy to take. Thank you very much for listening. Thank you so much for inviting me to this.